are you waiting for anyone, or there is some of you are sharing the same computer? Okay, attendance sheet must be sent to our sign officer, please. Okay. If someone has any problem with internet or like that, he must inform to try to help or take decision, please. Okay. So let us start by الكتاب. بسم الله الرحمن الرحيم. Yes, today we'll start by the nephrotic syndrome.
Yes, doctor.
A good design today. All of you are making a good design. Hoping you have also a good, inshallah, presentation and knowledge. Let's go. We are trying to finish within 2 hours, inshallah. Okay.
Okay, doctor.
Okay. Okay, start. Please try to mute your, all of you can mute, please, their voice, please. So no interruption for her.
Okay, doctor.
Make it full screen and go ahead.
Okay, so can everyone see my screen?
Yes.
Okay, so
Yes.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Syafiqah binti Bahtiar, and today I'll be presenting on nephrotic syndrome. First, this is the outline of my presentation. First, I'll be discussing generally about the nephrotic syndrome, and then I'll be discussing on the approach to nephrotic syndrome, and the last one is briefly about congenital nephrotic syndrome. So the first one, according to pediatric protocols, fourth edition, nephrotic syndrome is a clinical syndrome of massive proteinuria defined by edema, proteinuria, hypoalbuminemia, and also hypercholesterolemia. So as for proteinuria, it is defined as urinary excretion of more than 40 milligram per meter square per hour, or early morning urine protein creatinine index of 200 milligram per millimole. And for hypoalbuminemia, it is defined as serum albumin level below 25 gram per liter, and hyperlipidemia, where cholesterol level is more than 200 milligram per deciliter. So basically, the etiology for nephrotic syndrome is classified into three, which is primary, secondary, and also congenital nephrotic syndrome. But for congenital nephrotic syndrome, I'll be touched about it in the last part of the presentation. So the first one, we have primary nephrotic syndrome, or commonly idiopathic nephrotic syndrome, where there is absence of an identifiable systemic disease, and it is the commonest form of nephrotic syndrome. And it is most common in children aged between 2 to 6 years old, and more prominent in male, where the male to female ratio is 2 to 1. And one of the example of primary nephrotic syndrome is minimal changes nephrotic syndrome, which account for 85% of the total cases. Next, we have secondary nephrotic syndrome, where there is presence of an identifiable systemic disease, and it is suspected in patient in older children where the age is more than 8 years old and present with hypertension, hematuria, renal dysfunction, and so on. And the causes include infections, drugs, immunology or allergic disorder, and malignant disease. This is the table that summarizes the causes of childhood nephrotic syndrome. And we can see for idiopathic nephrotic syndrome will be discussed a little bit after this, where I'll be discussing on minimal change disease, messenger proliferation, as well as focal segmental glomerulosclerosis. And the next one is secondary causes of nephrotic syndrome, where we have infection, such as HIV, cytomegalovirus, and so on. And we have drugs such as captopril, NSAIDs, and also we have immunology or allergy disorder as well as associated with malignant disease. So next, moving on to the pathogenesis of nephrotic syndrome. So nephrotic syndrome is believed to be due to underlying abnormality in nephrotic syndrome is an increased permeability of the glomerular capillary wall, which lead to proteinuria and hypoalbuminemia. And the increased permeability of the glomerular capillary wall is due to the role of the podocytes and also the role of immune system. So first, let's take a look at the role of podocyte. But before that, let us understand the normal glomerular capillary wall. So basically, the glomerular capillary wall consists of three layers, where there are fenestrated endothelium, there are glomerular basement membrane, as well as epithelial cell with its food processes known as podocyte. And then food processes are separated by slit pores, which are closed by a thin membrane, the slit diaphragm. And in terms of permeability to macromolecules, um, for glomerular basement membrane and slit diaphragm is a major site for size selectivity. And for glomerular basement membrane and endothelium, it is a major site for charge selectivity. So in addition, various proteins contribute to complex signaling pathway and podocyte function, such as nephrin, podocin, CD2AP, as well as alpha-actinin 4, where any abnormality to the structure and function of this protein will also contribute to the abnormal function of podocytes. Okay, so next is let's see the role of podocytes in pathogenesis of nephrotic syndrome. So basically, when there's injury or genetic mutation to normal epithelial podocyte and glomerular basement membrane, this will cause extensive podocyte effacement. As we can see in this picture on the right, there's podocyte effacement where we can see the food processes. And then from the extensive podocyte effacement, there will be increase in glomerular permeability, and which will then lead to massive proteinuria and resulting in hypoalbuminemia. And then hypoalbuminemia will later cause decreased plasma oncotic pressure and cause reduction in effective circulating blood volume and also the activation of the RAS system. And this will then lead to sodium retention and causing the shifting of fluid from the intravascular to interstitial and leading to edema. Uh, in addition, hypoalbuminemia also stimulate lipoprotein synthesis, but with reduced lipoprotein metabolism. This will then lead to hyperlipidemia. So next, moving on to the role of immune system. So basically, in nephrotic syndrome, specific to minimal change disease, the role of immune system is described as a non-inflammatory immune response, where it is resulting from immune injury that usually target the podocytes. For example, we have T-cell derived factors, vasoactive agents, complement C5b9, and cytokines, which will directly induce sufficient podocyte dysfunction to result in proteinuria without inflammation. And this is also associated with major functional changes in the glomerulus, which will then lead to increase in glomerular permeability to albumin and other proteins. Since podocyte is separated from the circulation by the glomerular basement membrane, the immune deposit that target the podocyte seldom produce glomerular inflammation. Therefore, there's little to no edema. Therefore, there's little to no hematuria and red cell cast. So to add on to the hypothesis of the role of immune system in the pathogenesis of nephrotic syndrome is that in minimal change nephrotic syndrome, it also may occur after viral infection and allergen challenges. And also in MCNS also, it can occur in children with Hodgkin lymphoma or T-cell lymphoma. And also immunosuppression caused by the drugs such as corticosteroids and cephalosporin also contribute to the pathogenesis of the nephrotic syndrome. Okay, so this is the diagram that you can compare the normal glomerular capillary and also the glomerular capillary in the nephrotic syndrome. As we can see in the normal one, we have podocytes with the slit diaphragm over here, but in the nephrotic syndrome, there is podocyte effacement where we can see there is destruction of the slit diaphragm and so on, and this will then really lead to increased permeability of the increased permeability. So next, as I said that idiopathic nephrotic syndrome account for 90% of total cases of nephrotic syndrome. So I will be discussing on few types of idiopathic nephrotic syndrome. So the first one is minimal changes nephrotic syndrome, MCNS. This accounts for the majority of the nephrotic syndrome in children below 6 years old. And in minimal changes nephrotic syndrome, the glomeruli appear normal or show minimal increase in mesenchymal cell matrix. And for MCNS, the effacement of the epithelial cell food processes can only be seen under electron microscope. As for under light microscopy and also immunofluorescence microscopy, there's no significant findings. And in majority cases of MCNS, the child will respond to the corticosteroid therapy without advancing to kidney failure. So the prognosis for MCNS is good. So as we can see on the picture on the top right, we can see the comparison between the normal and the MCNS capillary wall, where in normal the protein is kept inside. But in MCNS, there is a protein spillage due to increased permeability of the capillary wall. So clinical manifestation of MCNS include mild edema, which can be on eyes and lower extremities, and it is decreased throughout the day and can become generalized with time. And for severe cases, there will be development of ascites, pleural effusion, and genital edema, and also presence with anorexia, irritability, abdominal pain, and diarrhea. And important features of MCNS is the absence of hypertension as well as absence of gross hematuria. So next is mesangial proliferation, which is characterized by diffuse increase in mesangial cells and matrix on light microscopy, traced to 1+ mesangial IgM or IgA staining on immunofluorescence microscopy. And on electron microscope, there's increased number of mesangial cells and matrix as well as effacement of the epithelial food processes. So as we can see on the picture on the right side, there's cellular proliferation limited to the mesangium, but there is well-preserved peripheral capillary wall. In mesangial proliferation, 50% of the patient respond to corticosteroid therapy. So the prognosis is poorer compared to MCNS. So next, the last one is focal segmental glomerulosclerosis. This is when the glomeruli show both focal and segmental lesion, where on light microscope, there's lesion consists of mesangial cell proliferation as well as segmental scarring. On immunofluorescence microscopy, there is positive for IgM and C3 staining. And for electron microscope, there is segmental scarring of the glomerular tuft with obliteration of the glomerular capillary lumen. So on the right side picture, we can see on the top left, there is moderately large segmental area of sclerosis with capillary collapse. And on the middle left, we have focal deposition of hyaline material. So, okay, so this is the general clinical manifestation of nephrotic syndrome. So most of the children that have nephrotic syndrome will present with edema. And this edema often occur after infection, such as upper respiratory tract infection or an insect bite. And then the edema is first noted at the periorbital area. So sometimes misdiagnosis of allergic reaction might be done due to this sign. And also the edema will increase gradually. The edema is gravity dependent, where early in the morning, the edema will be more prominent on the periorbital area, but over the day, the edema will be increased in the lower extremity area, but decreased in the periorbital area. And it also affects the scrotum, penis, and labia. And then the characteristic of edema is non-erythematous, soft, and pitting edema. And then next we have anascara. Anascara is a more severe form of edema, where it is characterized by marked peripheral edema. Abdominal distension might be due to ascites, marked scrotal or parvular edema, and also severe periorbital edema. As we can see on the right side picture, we can see the child have abdominal distension as well as marked scrotal edema. And then also in nephrotic syndrome, the children might come with the sign of decreased effective circulating volume, such as tachycardia, peripheral vasoconstriction, and also oliguria. And also abdominal pain can be present. This is due to peritonitis, as in nephrotic syndrome, the child will be more susceptible to the infection. So if there is peritonitis, if there is infection, it will be associated with fever. And then the next one is dyspnea. which is due to respiratory compromise from pleural effusion or ascites, but rarely due to pneumonia and pulmonary embolus. And then next is thromboembolism due to hypercoagulability, which is one of the complications of nephrotic syndrome. So the next one is approach to nephrotic syndrome, which is the first one. We have history taking, then physical examination, proceed with investigation and management and prognosis. So the first one, case scenario. AA, 44 years old Malay boy, was admitted to HTAA due to facial swelling for 5 days. So first, for history taking, we need to know the history of presenting illness. Since he come with edema, so we need to ask further about the edema, about the site of the swelling. Either it is only prominent on a certain part or it is generalized to the whole body. And also we need to know if the edema is intermittent or is insidious onset. Also the characteristic of the edema, which soft, pitting, and non-erythematous edema in MCNS. And also we need to know if the edema progress rapidly or slowly, and also the time course of edema, like I mentioned before about the gravity dependent. And then the next one, we also ask about the associated symptoms. If there is any diarrhea, which will, if there is presence of diarrhea, we need to know about the onset, duration, and frequency. And we also need to ask for the urination. We need to ask about the urine output, and also if there is any frothy urine or dysuria, which may be symptoms of proteinuria, and also if there is any hematuria. But however, hematuria is more common in glomerulonephritis and also nephritic syndrome compared to in nephrotic syndrome. So next, we can also ask a symptom of hypertension. This is due to hypovolemia, which include headache, chest pain, and vision problem. And the others, we can ask about weight changes. This may be associated with malignancy or poor nutrition. And also we can ask about anorexia and irritability. And we can ask also about the abdominal discomfort. This might be due to peritonitis due to infection. And also we can ask about the dyspnea. So the next one, okay, so the next few history that I'll be mentioning is just to identify the possible causes of the nephrotic syndrome or to assess the risk factor of the nephrotic syndrome. So the first one, we look at the past medical history where we ask if the swelling is preceded by infection. Because in MCNS, the edema is preceded by the infection. So we can ask if there is any presence of fever, skin infection, or sore throat, and seek contact prior to the edema. So we need to also ask about the history of renal disease and history of same illness. As for example, for nephrotic syndrome, we need to ask if the patient have had the episode of nephrotic syndrome before, because we want to determine if the patient is a first timer or it is a relapsed nephrotic syndrome, because the management will be different. So next is history of infection, as I mentioned, that nephrotic syndrome will increase the susceptibility to infection. And also we need to ask about history of heart disease. This is to exclude cardiac edema. And the last one, we ask about history of joint pain, stiffness, photosensitivity rash, and so on to exclude SLE. Next, we ask about drug history, which is traditional medication or nephrotoxic drug. For example, the drug that can cause secondary nephrotic syndrome, for example, captopril and also NSAIDs. And also we need to ask about the family history, if there is any history of renal disease, congenital disorder, or autoimmune disease. This is to assess, if this is present, this might be the cause of the nephrotic syndrome. So next we ask about immunization history, nutrition history, and also birth and developmental history. So moving on to the next one, which is physical examination. So as for general examination, we assess the well-being of the patient, either they are well or ill-looking. And next, we assess the facial puffiness, and then we assess if there's any presence of pallor, jaundice, or cyanosis. And also we observe the size of the child and also the nutritional status. And then proceed to the vital sign, where there will be present of fever if the nephrotic syndrome is associated with infection. And also for the blood pressure, it can be hypertension or hypotension. However, hypertension is more common in glomerulonephritis and also nephritic syndrome. And also we need to assess for the pulse rate and also respiratory rate. Next, we assess for the hydration status, such as hypovolemia. In hypovolemia, the child can present with a cold periphery, poor capillary refill time, also poor pulse volume, and also low blood pressure. And for hypovolemia, the child can be present with bypassal crepitation, bronchi, hepatomegaly, and also hypertension. So next is the systemic physical examination, where the first one we look at the skin if there is any features of SLE, which is rash. Next is on the eye, we see if there is any periorbital edema, and then limbs. We need to see if there is bilateral pitting edema of lower extremity. Next is respiratory examination. This is just to assess the possibility of having pleural effusion, because pleural effusion is one of the complications of nephrotic syndrome as well. Next, we examine the abdomen, where on inspection, the abdomen might appear distended, and on palpation, there might be tense and tenderness if there is any inflammation. And on percussion, there is fluid trill and shifting dullness due to free fluid. And also on auscultation, we expect normal bowel sound. On cardiovascular examination, this is to assess if there's murmur or gallop rhythm, which can determine if the causes of the edema is from the heart disease. So next is investigation. So basically, nephrotic syndrome can be diagnosed clinically and confirmed with investigation. So in investigation, we need to assess for the characteristic of nephrotic syndrome that we have mentioned before. The first one is proteinuria, hypoalbuminemia, and also hyperlipidemia. So first, let's take a look at the urine test, where there's urinalysis, where there's high urine albumin concentration of 3+ or 4+ on urine dipstick. Next is urine protein excretion, where there is proteinuria of 40 milligram per meter square per hour, and then protein to creatinine ratio on first morning specimen more than 2. And then for blood tests, we assess for serum albumin to look for hypoalbuminemia of less than 25 gram per liter, and also we look at the lipid profile. This is to assess for hyperlipidemia. Next is full blood count. This is to assess for hemo concentration and also thrombocytosis, because I mentioned thromboembolism is one of the complications of the nephrotic syndrome. So the next few investigation is just to assess other causes of nephrotic syndrome. So for example, we have complement study, where in complement study, it will be normal in MCNS, and there will be low C3 in membranoproliferative glomerulonephritis and low C3 and C4 in lupus nephritis. So by the presence of complement studies, we can differentiate between each causes. And then on imaging, we can do chest X-ray, but this is only indicated if there is respiratory symptom present that might be associated with pleural effusion. So the next one is the management. This is the outline of the management. So the first one, we can manage the patient as outpatient, but management as outpatient is only indicated for the first episode of nephrotic syndrome and also for mild to moderate edema. So, however, if we want to manage as outpatient, the parents must be able to recognize the sign and symptom of complication, and also the parents must know how to conduct and interpret the urine albumin. So, for management as outpatient, if there is albuminuria of more than 2+ for 3 consecutive days or 3 out of 7 days, they need to consult doctor directly. And also they need to consult the doctor if there is presence of edematous, regardless of the urine dipstick result. Next is general management. So basically we give a normal protein diet. This is just for the nutritional support. And then we can give broad spectrum antibiotics such as penicillin. This is as prophylaxis from infection. So penicillin is recommended at diagnosis and during relapse, and particularly in presence of gross edema. The next one, we need to assess for the hydration status I have mentioned before. And then we can give diuretics, but diuretics can only be administered when needed. And it must be administered with caution because it can precipitate hypovolemia. And also we can give human albumin with diuretics. This is to induce diuresis. So the next one is the corticosteroid therapy. So as I mentioned that most of the total case of nephrotic syndrome is MCNS. So our initial treatment will be with corticosteroid therapy, where we give initial prednisolone therapy for 60 milligram per meter square per day for 4 weeks. Then we proceed with alternate day prednisolone per day for 4 weeks. Then we continue with the taper dose for 4 weeks, and then we stop. So there are a few outcomes of this corticosteroid initial therapy. So the first one is response. Response is defined by when the child attain remission within the initial 4 weeks of therapy. And then remission is then defined by urine protein creatinine ratio of less than 0.2 or less than 1 plus protein on urine dipstick for 3 consecutive days. Then we have relapse. Relapse is defined when urine creatinine ratio is more than 0.2 or a reading of 2 plus for 3 plus consecutive days. And then we have frequent relapse, where the relapse occur 2 or more times within 6 months or occur 4 times within a 12 months period. And then we have steroid dependent, where the relapsing occur during the steroid tapering or relapse within 2 weeks discontinuation of therapy. And the last one, we have steroid resistant, that inability to induce remission within 4 weeks of daily steroid therapy. So basically, this is the outline for the management of nephrotic syndrome, where we begin with the initial episode of nephrotic syndrome. If there is response, we continue with the alternate dose, and also we give the taper dose for over 4 weeks and stop. But if there is relapse, we give prednisolone till remission is gained, and then we continue with 40 milligram alternate day for 4 weeks. Then we stop. We does not taper the dose at this moment. So next, if there is frequent relapse, we reinduce as relapse, and then we add on the taper and keep low dose alternate day for 6 months. Then if there is relapse while on prednisolone, we will treat as frequent relapses. But if there is presence of steroid toxic, we will give a steroid sparing agent, for example, cyclophosphamide. So now let's see steroid sparing agent. So who are steroid sparing agent are indicated for? They are indicated for steroid dependent nephrotic syndrome, frequent relapser, and steroid resistant patient which have the sign of nephrotoxicity, steroid toxicity. So the first one, the most common, we have cyclophosphamide therapy, where it is given as single oral dose for a duration of 8 to 12 weeks. However, during cyclophosphamide therapy, we might also give the alternate day corticosteroid therapy. And also, cyclophosphamide therapy is believed to prolong the duration of remission and also to reduce the number of relapse. However, we need to monitor the side effect of the drug closely. So then we have other few steroid sparing agent. Next is intercurrent infection. So basically, as I mentioned, nephrotic syndrome patient is more susceptible to infection. So most of the time, the relapse is triggered by the infection. So in order to reduce the relapse, we need to reduce the relapse, we need to give prophylaxis. So basically, we can give temporarily increase the dose from alternate to everyday for 3 to 5 days, meaning that during the alternate therapy, we can increase the dose to the normal one, to the initial one. Next, we have steroid resistant nephrotic syndrome. So steroid resistant is when they fail to achieve remission in the 4 weeks initial treatment. So if there is steroid resistant, we refer the patient for renal biopsy, and we will see the actual causes of the nephrotic syndrome, and we will manage accordingly. Then we have general edema of the sign and for the symptoms. Okay, next for management and for immunization, while the child is on corticosteroid treatment and within 6 weeks after its cessation, only killed vaccine may safely be administered to the child. And we can only give live vaccines 6 weeks after cessation of the corticosteroid therapy. And in all children with nephrotic syndrome, we must give pneumococcal vaccine because because pneumococcal is the most common infection that associated with nephrotic syndrome. And if possible, we give when the child is in remission. Next, we have acute renal crisis. That may be seen in children who have been on long-term corticosteroid therapy. And we can give a hydrocortisone. Okay, next is prognosis. Okay, so I divided prognosis into two, which is steroid responsive and steroid resistant. So basically, for steroid responsive, there's repeated relapse with decrease in frequency as they increase in age. And children who respond rapidly to steroid and those who have no relapse during the first 6 months are likely to have a better prognosis. And then the steroid responsive child is unlikely to develop to chronic kidney disease. But for steroid resistant, they have much poorer prognosis, where there's development of progressive renal insufficiency that can lead to end-stage renal disease requiring dialysis or renal transplant. So we have to manage the patient and plan for the dialysis and also renal transplant. So the next one is complication. First, we have hypovolemia, where the clinical features are abdominal pain, cold peripheries, and so on. And this treatment, we can infuse human albumin at 0.5 to 1.0 gram per kilogram which, per dose. And then we have peritonitis, which is associated with infection. And then the treatment, we can give parenteral penicillin and a third generation cephalosporin that is a broad spectrum antibiotic. And then we have thrombosis. Thrombosis can be occur due to hypercoagulable state resulting from the vascular stasis and also intravascular volume depletion. So treatment we give anticoagulant. So the next one, we move on to the last part, which is the congenital nephrotic syndrome. So, congenital nephrotic syndrome is defined as nephrotic syndrome manifesting at birth or within the first 3 months of life. And then the prognosis is poorer, as the prognosis of the nephrotic syndrome is poorer when it is manifest in the first year of life. So we can divide congenital nephrotic syndrome into primary and secondary, where primary it is due to variety of syndrome inherited as autosomal recessive disorder, and there are structural and functional abnormalities of the glomerular barrier. So there are 4 types of primary congenital nephrotic syndrome. So the first one, we have the Finnish type, where there's mutation in NPHS1 or NPHS2 gene. And this gene is crucial for the encoding of the nephrin and podosin, which are important protein in the glomerular capillary, as I mentioned earlier. Next, we have Dennis-Drash syndrome, which is mutation in WT1 gene, where this will lead to abnormal podocyte formation. And then we have Pearson syndrome, where there's mutation in LAMP2 gene, and there will be abnormality in the podocyte. And then the last one, we have Galloway-Mowat syndrome. As for secondary, this might be due to in utero infection, infertile SLE, and also mercury exposure. And this will resolve with treatment of underlying causes. So the example of the causes can be syphilis, cytomegalovirus, hepatitis B, HIV, toxoplasmosis, and so on. And then, for congenital nephrotic syndrome, the clinical features are anoscara and enlarged placenta at birth. And then they will have hypoalbuminemia and also oliguria. So basically, congenital nephrotic syndrome can be diagnosed prenatally, where there is elevated alpha fetoprotein levels in maternal serum and amniotic fluid. And for diagnosis, it can be made clinically, where there is severe generalized edema, poor growth and nutrition, hypoalbuminemia, increased susceptibility to infection, and increased risk of thrombotic events. And most of the infants have progressive renal insufficiency. So the management, we give intravenous albumin and diuretics, and also we give nutritional support aggressively. And then we can give ACE inhibitor, angiotensin 2 receptor inhibitor, and also prostaglandin synthesis inhibitor. And for the complication, the child may fail to thrive and have recurrent infection, hypothyroidism, as well as progression to renal failure into 2 to 3 years. So they need to plan earlier about the dialysis as well as the renal transplant. So yeah, that's all from me. And these are my references if you wish to further read about the content that I have talked about. So is there any question?
May I ask,
Yeah.
why in the physical examination, in the part of hydration status, you mentioned about hypervolemia? Hypervolemia. Is there any relation with the nephrotic syndrome?
Yes, because in nephrotic syndrome, there's 2 hypotheses such as is overfill or there is hypovolemia. Yep, I will. Because in the pathogenesis, I mentioned that there will be reduced effective volume circulation. So that will lead to the hypovolemia. Yeah.
This is an important challenge with patient with nephrotic syndrome. He has over fluid, he has fluid overload causing edema, but at the same time, the intravascular fluid are very shrinked. So he may get like hypovolemia manifestation, even shock, while he has overflow. That's why we must be very judicious in treatment game, especially with with albumin infusion, and be meticulous when you are going to giving the diuretics. We are not giving it as a routine, because protein alone will put the fluid from the extracellular fluid to the intracellular one. Okay, good. Any other question? So now I think you did a good presentation, Shafika. We just need to ask you simply, if you found a baby with edema, what you are going to do? Periorbital edema, clinically now.
I can hear you clearly. Yep.
You cannot hear me. Okay. Can you hear now? Can you hear me or not?
Doctor, can you repeat the question?
Yeah, a baby now came to you with periorbital edema. How you are thinking now to manage that child, and came to diagnosis and investigation?
Maybe I will assess if there is any part of the body of the baby there is edema, and also ask about the history, if it is associated with allergic reaction and so on.
Hmm? Okay, what else?
I'm not sure.
Yeah, so as you speak, that's why. The number one, if I found any symptom, I would like to clarify how extensive is it? Okay, is it only on the face or in other place? So what other place you spoke about?
The lower extremities,
Okay,
scrotum, and also the abdomen.
okay, what else?
What else?
Genitalia, what
Yes.
else?
Lower extremities,
Okay,
and then
Mhm.
abdomen,
Abdomen for
ascites, abdominal distension for
what
ascites.
else? Sacral edema, if he is recumbent. Okay, what
Yes.
else? The chest, which is very important to check for any pleural effusion or pulmonary edema.
Yes.
So number one, if you found any symptom, you must go to the severity of it. How severe is it? Okay. Number one, what if you are going to examine now? Which system you are going to examine?
Sorry, doctor.
What system you are going to examine for this edematous baby?
System that we exam is cardiovascular, respiratory, and also abdominal.
Okay, so let us concentrate in abdomen, because abdomen will give us a lot of knowledge. So how can you examine the abdomen? Sorry, what you are searching for?
Searching for if there is any distension, tenderness,
Okay.
and also for shifting dullness or fluid.
No, we must have normal flow before shifting the dullness. For any examination, we have inspection, palpation, percussion, auscultation. Okay, so for inspection, you speak good. I am going to check if there any distension, is there any stria. Is it stria are important?
Yes, I read about it, but I don't know what it's for.
Yes, because the steroid can cause some lesion known as stria rubra. If you remember, you got ONG, there is stria alba, which is because the stretch there is alba, but for corticosteroid is rubra. So you must add one slide about the Cushing syndrome, because you are giving steroid for a considerable time, especially if it is resistant or dependent. So you must make one slide about the Cushing syndrome. Sometimes it will come to the exam as Cushing only because the baby has no edema. Okay. So after you start by inspection of the abdomen, then you did palpation, superficial and deep. Okay. For deep palpation, you are going to examine 3 organs, which is
Liver,
okay.
spleen,
Yes. What is the third organ?
intestine.
No, the kidney.
Oh yeah, kidney.
The
Okay.
kidney. Your problem with nephrotic syndrome is in the kidney. So liver and spleen, we must start by the right iliac fossa and go up until we can get the lower tip of the liver. Okay. And then I am going to do percussion, okay, from right iliac fossa, because sometimes the liver, if it is very big, I may miss its lower tip. Percussion until, and then go for the upper border of the liver from the chest and go the liver span. For the spleen also, I will start from the right iliac fossa the same and go in the direction of the spleen. Okay, it is very important and percuss the TROPS area to rule out any splenomegaly. Okay. For the kidney, I am doing ballotments, which is different. Okay. So it is very important to know how to approach the patient clinically. It is a good to give us example just to think about, but how to approach for clinical points are very, very important for us. Okay. So now we speak if they have patient with edema, we must be able to say is this edema related to kidney, to the heart, to the allergy, to immune, to liver. It is very important, okay? Also for the issue of spontaneous peritonitis, you must manage it because this patient usually got susceptibility to infection. Generally, it is not only one of the most famous is the spontaneous peritonitis. But you must answer the question why this child has susceptibility to infection. Okay. And then the Cushing syndrome, as we speak before. Okay. Okay. Good. Well done preparation and the presentation. Hoping inshallah, I see you a good presenter with the future. Your mark will be 8. Okay.
Thank you.
Okay, let us go for the second presentation.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Can everyone see my slide?
Yes.
Alright, thank you. Okay, so Bismillah. So my name is Nurul Hanan binti Muhammad Fuad, and I will be presenting about acute glomerulonephritis. Okay, so this is the outline of my presentation. Alright. So first we go to the definition of acute glomerulonephritis. So acute glomerulonephritis is a specific set of renal disease which immunological system triggers inflammation and proliferation of glomerular tissue. And then according to pediatric protocol, acute glomerulonephritis is an abrupt onset of one or more features of an acute nephritic syndrome. Which include edema, microscopic or macroscopic hematuria, oliguria, hypertension, and azotemia. Right. So next, we go to the epidemiology of acute glomerulonephritis. So glomerulonephritis represent 10 to 15% of glomerular disease, and worldwide, the most common cause of glomerulonephritis is IgA or immunoglobulin A nephropathy, while in Malaysia, the most common cause is post-streptococcal glomerulonephritis. So, specifically for post-streptococcal glomerulonephritis is more common. Is most common in children, ages around 5 to 12 years old, and typical patient will develop glomerulonephritis 1 to 2 weeks after antecedent streptococcal pharyngitis, or it can develop 3 to 6 weeks after streptococcal pyoderma. And this glomerulonephritis is more common in males rather than females, which ratio 2 to 1. Okay, so for the etiology of acute glomerulonephritis, there are infectious cause and also non-infectious cause. So for infectious cause of glomerulonephritis can be due to bacteria, infection of streptococci, staphylococci, and also mycobacteria, but the most common is the streptococci. It can also be due to viral infection, herpes viruses, and hepatitis B. And it can also be due to fungi and parasite infection. And for the non-infectious cause, the glomerulonephritis can be due to multi-system systemic disease such as vasculitis, systemic lupus erythematosus (SLE), Hinox conlin purpura (HSP), or also known as IgA vasculitis, and also Goodpasture syndrome. While for the other cause, glomerulonephritis can also be due to primary renal disease, secondary to the primary renal disease such as IgA nephropathy, hereditary nephritis or Alport syndrome, membranoproliferative glomerulonephritis, and also rapidly progressive glomerulonephritis. Okay, so I will just explain a little bit about the pathophysiology of glomerulonephritis. So it can be due to two mechanisms. The first one is deposition of immune complexes into glomerulus from circulation. So when if there is a circulating immune complex in the circulation, there will be passive deposition into the glomerulus, and it will cause immune complex deposition in glomerulus. Other mechanism, it can be due to in situ immune complex formation in glomerulus, which occurs when there will be in situ bindings of antibodies with localized with antigen that is localized in glomerulus, and the antigen can be structural glomerulus antigen, but glomerulus antigen, and it can also be antigens from that is trapped, such as self antigen, such as DNA, and it can also be exogenous antigen from infectious agent. So the antigen will be trapped inside within the glomerulus, and when there will be antibodies binding to antigen, so there will be formation of immune complex. So when there is deposition of immune complex, there will be inflammatory response, and this inflammatory response will occur, and it can also proliferate the cell, proliferate the glomerular cell, and when there is um, inflammatory response, so there will be damage to the capillary walls. Therefore, it will increase the permeability of the capillary walls, and red blood cell and protein can be can exit. So therefore, patient can be present with hematuria and proteinuria. At the same time as there will be increased cell proliferation, so the increased glomerular cellular will restrict the glomerular blood flow. So the glomerular filtration rate will decrease. So it will lead to reduced urine output and fluid retention, and can be presented with hypertension and also pulmonary edema. Okay, so this is the image of pathogenesis. So if you want to go more, if you want to just revise, you can look at it later. All right. So next, for the approach to acute glomerulonephritis, I prepare a case scenario. A 9-year-old boy presented to HTAA with complaint of hematuria for 1 week duration. So we should ask more about the presenting complaint, the hematuria, about the color of the urine, characteristic, volume of urine, and also if it is painful or painless. So hematuria usually is characterized by cola colored urine or smoky colored urine, and if the volume is small, if the urine volume is reduced, so it is oliguria. So it is one of the acute nephritic syndrome. So the patient had cola colored urine, quite frothy, small volume of urine, and he does not feel any pain during urination. We should also ask about other symptoms such as fever, and because if there is fever, it might there is other underlying systemic disease. If there is edema, headache, shortness of breath, and also visual disturbance. Okay, so for the headache and headache, shortness of breath, and visual disturbance is symptom of complicated glomerulonephritis. Okay, so patient had fever and sore throat 1 to 2 weeks ago, and did not have the symptoms. So the patient might have post-infectious glomerulonephritis and most likely be due to streptococcus infection. Okay, so this is the clinical features of post-streptococcal glomerulonephritis. So there are specific symptoms such as edema, facial puffiness, smoky or tea colored urine, and reduced urine output. Other non-specific symptoms such as anorexia and lethargy and abdominal pain. And if there is complication, um, patient may have shortness of breath that indicate pulmonary edema, dizziness, headache, that is hypertensive encephalopathy. And the signs of there are cardinal. This is the cardinal features of acute glomerulonephritis, which is edema, hematuria, proteinuria, uremia, oliguria, and hypertension. For okay. So we should also ask about the past medical history to identify possible etiologic agent such as the streptococcal infection. And we should also ask about any underlying systemic disease such as SLE or HSP, hinox scanloid purpura. And also we should ask about the birth history, immunization history, nutritional history, drug history, and also family history if there is any family with autoimmune disorder, or if there is any hereditary disease of hereditary nephritis. And also we should ask if there is any family history with renal failure that have dialysis. Alright, so next, this is the complication of glomerulonephritis. So it can be hypertensive encephalopathy. The patient, if it is in early stage, the patient may have restless, drowsy, headache symptoms. If it is in a late stage, the patient may have visual disturbance, vomiting and nausea, seizures, and also coma. Other complication is pulmonary edema due to fluid retention, and if in renal, and there can be nephrotic syndrome, rapidly progressive glomerulonephritis, and also irreversible renal failure. For blood, the patient may have severe uremia and also hyperkalemia. So the patient may present viscous mouth breathing due to metabolic acidosis and also cardiac arrest due to cardiac arrhythmia. So next, we go to the physical examination. So first we have to do general examination. We observe if the patient is conscious and alert, if the patient is lethargy or fatigue, if the patient is in respiratory distress, which is one of the symptom of pulmonary edema, and then we look at the patient at the face. If if there is any sign of facial puffiness, and if at the eye, it's periorbital edema. So the patient may have edema, and at the neck, cervical lymphadenopathy, and we look at the skin if there is any rashes. So it might be the cause might be due to uh, HSP, and then we look at the leg for lower limb edema, and then we do anthropometric measurement, and then we look at the vital signs of the patient. So usually for if patient with glomerulonephritis, there will be hypertension, increased blood pressure. Then cardiovascular, there might be heart murmur, and respiratory, we can maybe hear crepitation during auscultation that shows there may be pulmonary edema. And also we check at the abdomen if there is any abdominal pain or any organomegaly. So this is the picture of facial puffiness and periorbital edema. So the patient was alert and conscious. There was mild facial puffiness and also had mild hypertension, but there was no hepatosplenomegaly or any skin rashes. Alright, so for the investigation, we can do full blood count. At the full blood count, we can find leukocytosis, which is increase in white cell count, which indicate there is infection. And then we can do renal profile. We look for blood urea, serum creatinine, and electrolyte. So if there is increase in blood urea and serum creatinine, so there might be um, reduced renal function. And then we can look for complement level because of the post-streptococcal glomerulonephritis is immune response mediated. So if usually the C3 level will be low at the onset of symptoms, but it will normalize by 6 weeks. And C4 level usually within normal range in post-streptococcal glomerulonephritis. Then we can also do immunological marker, anti-nuclear and anti-dsDNA antibody to exclude SLE. And also we can do anti-neutrophil cytoplasmic antibody to exclude vaginous granulomatosis, which is also one of the cause of glomerulonephritis. And then we can also do bacterial and serological evidence. If there is raised anti-streptolysin or titer, it is most likely to be post-streptococcal glomerulonephritis. And you can also do anti-DNase B, which is a better marker to look for streptococcal infection. And then we can also do throat swab or skin swab to confirm if there is any infection. And then we can do urinalysis, and we check for hematuria, proteinuria, presence of RBC cast or other cellular cast, and pyuria may present. And also we can do imaging. We can do chest X-ray to look any pulmonary edema. And then we can also do renal ultrasound and biopsy. So the indication for renal biopsy is when there is steroid resistant, or there is atypical presentation or severe renal failure, or if there is any prior history of renal disease or family history of nephritis. And also if the presenting features suggest there is non-post-infectious acute glomerulonephritis as the cause of glomerulonephritis, and if there is delayed resolution of oliguria, azotemia, hematuria, and also gross hematuria more than 3 weeks, and persistent hematuria. So we can do renal biopsy to confirm the diagnosis of the the cause of the glomerulonephritis. Okay, so what we can do to manage a patient with acute glomerulonephritis, there is supportive management and also specific management. For supportive management, we can first strict monitoring. We have to monitor the patient and make sure that the patient is stable. So we should monitor fluid intake, urine output, daily weight, and also blood pressure. And then we should also give penicillin V for 10 days, or you can also give erythromycin if penicillin is contraindicated. This is to eliminate beta hemolytic streptococcal infection. And then we should also restrict fluid intake to control edema and circulatory overload. And we should also give diuretics with to patient with pulmonary edema and also for hypertension treatment. And also for the diet, we should give patient diet without salt, and also look out for complication of glomerulonephritis such as hypertensive encephalopathy, pulmonary edema, and also acute renal failure. And if the patient is unresponsive to diuretics, we should do dialysis. In patient with acute pulmonary edema, hyperkalemia, severe acidosis, and also if the patient have presenting uremic symptoms. Right, for the specific management, for the hypertension, we can give hypertensive medication to control the blood pressure until to control the blood pressure. And if there is severe acute kidney injury, which is uncommon in children with post-streptococcal glomerulonephritis, but if there is a severe acute kidney injury, we can do peritoneal dialysis and also hemodialysis. And if the patient is present with pulmonary edema, we can manage by giving oxygen and ventilatory support if necessary. We can also do IV diuretics and restrict the fluid intake. But if the patient is not responsive to those, we can consider dialysis. Okay, so follow-up of the acute post-streptococcal glomerulonephritis. After hematuria and proteinuria fully solved, we should follow up the patient for at least 1 year at 1 to 3 months interval. And we should also monitor blood pressure at every visit and also do urinalysis and renal function to evaluate the recovery. And we should repeat C3 levels 6 weeks later if it is not normalized by the time of discharge. Okay, so for prognosis, usually it is complete recovery, and it is more than 95% children with acute post-streptococcal glomerulonephritis will have complete recovery, and for recurrence are extremely rare, and mortality in the acute stage can be avoided by appropriate management of acute renal failure, cardiac failure, and hypertension. But very rare and infrequently, the acute phase is severe and will lead to glomerulosclerosis and chronic renal disease in less than 2% of affected children. I think that's all. Is there any question?
Yeah, can you explain a bit on the what we call hypertensive encephalopathy mentioned? Hypertensive encephalopathy.
For the hypertensive encephalopathy is the one of the complication of the acute glomerulonephritis. So when there is, as I mentioned before, so when there is increased proliferation of cell in the glomerulus, so there will be reduced GFR. So when there is reduced GFR, there will be reduced urine output, and also there will be fluid retention. So the fluid will there will be fluid overload. So the patient may present with hypertensive encephalopathy, if I'm not mistaken.
Thank you.
Yeah, this is an important presentation which we must take care because if the patient came in convulsion, usually you are thinking about other causes in the CNS. If you are not able to pick the issue of the blood pressure, that's why I used it to tell you vital signs are vital. You are not allowed to miss it because it will guide you. Just a patient came before to us with a convulsion, just to get the vital signs. We found the blood pressure is high. We said it may be due to the convulsion itself. Let us settle the convulsion. We measure. So we found, okay, that the blood pressure is still high. We asked the mother. She said she feels that the urine are changed in the last few days. So we go ahead and found it as a post-streptococcal glomerulonephritis. That's why in medicine you must have opened the eyes and the ear for any details, okay? Do you have any other questions? So I would like to ask Hanani now. This patient has hematuria, yes?
Yeah, yes.
So why the blood is not blood, why the urine is not bloody? You tell me it is hematuria, there is no fresh blood, there is cola or tea color. Why?
Sorry.
Why it is not bloody? The urine is not bloody. It is cola color.
Uh, what? I don't know.
Is it clear for you, my question?
Yes.
It came to you now, he is voiding blood urine, fresh blood urine. And but you are telling me it is hematuria, but the urine looks like tea color or cola color. What is the difference between both of them?
I'm not sure.
Yes, this is a very important because the bleeding now is coming from up from the glomeruli, from the kidney, okay? And it is distracted and cause hemoglobinuria like that. So it will come as a smoky color or cola color. But if it is fresh blood, even usually it will come from down, from cystitis like that. But if it comes from up, it will be something dangerous like malignancy, like stone, which is making eruption of the blood vessel like that. That's why glomerulonephritis, usually the color will be tea or cola. And it is very important to notice that because many times you will find beside the patient on the table his bottle of urine. You will find one very dark and then less dark and then looks normal. It means the progress of the EGE, okay, acute glomerulonephritis, AGN. This is a very important point, okay? The other thing for glomerulonephritis, the differential diagnosis. You told us it can be post-infectious, and the post-infectious are very wide. Usually in our country, the most common one is post-streptococcal glomerulonephritis, but as you speak, it can be many, even some viruses like Epstein-Barr virus, it can be a lot of, but what is the most common cause after post-infection?
Common cause
After the post-infection glomerulonephritis or post-streptococcal glomerulonephritis is the
after if I'm not mistaken, after post-infectious glomerulonephritis, the most common is primary renal disease,
IgA.
IgA nephropathy.
Remember that IgA, if you cannot find the infection, still glomerulonephritis can be due to IgA nephropathy, okay? Which is a very common in developed countries now because infection there is less, okay? The last question for you, Hanan. If I am the father of a baby, of child with post-streptococcal glomerulonephritis, what is the prognosis for my baby or for my child?
The prognosis of acute post-streptococcal glomerulonephritis.
Yes.
Usually, the patient can be completely recovered. The prognosis is high.
Continue.
Because most than 95% patient with post-streptococcal glomerulonephritis can be completely recovered.
So do I, that's good. More than 95, my child will be okay. So after discharge, I need to come again or not?
Yes, we should do follow-up for the patient for at least 1 year.
Oh, you tell me it is a very good, but I need to come to you for 1 year.
Because we should monitor the kidney recovery.
Okay, what else? But the kidney function is normal. You told me it is normal.
We should also look if the hypertension is resolved.
Yes, hypertension, okay. So this is an important point. We are supposed to be a doctor which has an important social job. You must be able to communicate with the patient, to convince them. The first case, your colleague must convince the family that your child needs corticosteroid 60 milligram per square, 40 milligram per square meter or like that, up to 60 milligram. And then you are going to decrease it. And the family may find them getting a big number of pills for their disease, which is steroid, and you tell them it can cause some side effect like Cushing syndrome. So you must be able to convince the family that these treatments are very vital for their baby. It will save their kidney, even if it got some side effects. For you, you must be very cautious. You must be said like, in spite this disease has a good prognosis and the mortality are very low, but we need to follow up the patient for 1 year because we are concerned about the kidney. We need to repeat the kidney function many times. We must know that the blood will not be visualized by the eye, by still he has microscopic hematuria for up to 6 months or more. So I need to know, is there still blood in the urine which you cannot see at home or not, okay? And also for the blood pressure and also for the source of infection. So please, we need to see the patient regularly until we discharge him. Because some people may understand that the prognosis are very good, so they will goodbye. It is very good prognosis, no need, okay? So we must be very meticulous, please. Start early, how to speak to the family, how to give them the important knowledge, how to teach them. Otherwise, the patient may be maybe the, okay? Thank you, good. Good preparation. Yeah, your mark will be 7.5. Hanan, okay?
Thank you, Doctor.
You are welcome. Let's go for the next presentation.
Okay. Can you see my slide?
Yes.
Okay. Assalamualaikum warahmatullahi wabarakatuh. So today I will present about the urinary tract infection in pediatric. So this is my outline, which is I will talk about the introduction of UTI and also causes and risk factor, pathogenesis and also sign and symptom, complication of the UTI and also the prevention of the UTI. And also for the last one, I will talk about how to approach the UTI patient. So the first one, okay, definition of the UTI. As I see in my UN textbook, it says that it is the growth of the bacteria in urinary tract. And also it is the combination of the clinical feature and also the presence of the bacteria in the urine. So we move next, which is the epidemiology. So in this case, about 3 to 7% of the girl and also 1 to 2% of the boy have at least one symptomatic feature of the UTI before the age of the 6. And also about 12 to 30% of them have the recurrence of UTI within a year because of some maybe in improper hygiene. This is causes of the UTI in children. Actually, it divided by 3. The first one is for the upper urinary tract infection. The first causes is the pyelonephritis. Actually, pyelonephritis is divided by 3, as I found in textbook. It's actually acute pyelonephritis, which is the involving the renal parenchyma, and also when they have a worsen, it will lead to the pyelonephritis scarring. So next, which is the pyelitis, which is the infectious with no parenchyma involvement. And also the last one is xanthogalomatous pyelonephritis, which is this type of pyelonephritis is actually rare because the condition is granulomatous inflammation with giant cell, and it show the foamy histiocyte. So next, we proceed to the cystitis, which is the lower urinary tract infection. So it actually divide by 3, which is the acute hemorrhagic cystitis, which is caused by E. coli, and also some uh, other causes, which is adenovirus type 2. So in this acute hemorrhagic cystitis, the symptom that I found is it will lead to the what we call it have a hematuria. And also for the next next type cystitis, which is the eosinophilic cystitis. It is rare actually because the condition is multiple solid bladder masses, consists of the histological of inflammatory infiltrate with eosinophil cell. So the last cystitic type, which is the interstitial, which is the chronic condition, causes the bladder pressure, pain, and have a irritative voiding symptom like agency, maturation, frequency, and also dysuria. So for the last causes, which is the asymptomatic bacteria, this asymptomatic bacteria, the commonest bacteria that are found in UTI in children, which is the E. coli. So it is a condition when the culture urine is positive. So we may detect on the urine culture, and also it more common on the girls than boys. So we proceed to the next, which is the risk factor. Actually, risk factor I divide by two, which is host and also the pathogen. So for the first, which is the anatomic difference, which is female, because they have a what we call shortened ureter, so it will be easy to um, it will be influence the more gain to the infection. So next, vesicuratory reflux. It actually the condition which the retrograde flow of urine from the bladder up to the ureter and collecting system. So next, risk factor is for the incomplete bladder emptying. As you can see, it is caused by the obstructive uropathy for the constipation, and also the neuropathic bladder for the spina bifida, and also for the vulvitis. And for the facilitation of entry organism, it actually when some patient admit to the ward, maybe it will be catheterization. So actually the catheterization not only for the pediatric patient, they will infect they will got infection, but also for the older is same too when they have a catheterization. And next is for the surgery instrumentation cystoscopy, it will lead increased risk of the infection also. And for the behavioral activity is which is the toilet training and also the toilet hygiene, because some what we call children, they might be what we call they clean after the maturation, maybe it's not proper hygiene. So next, it will be the sexual abuse. This is the dangerous case, and it will increase to the infection too. So next, anatomical anomaly, which is the example is labia addiction. So next for the pathogen, actually the common that will infect the urinary tract is the bacteria infection, because as I mentioned, the commonest bacteria is E. coli and also Proteus and Pseudomonas. But in what we call parasitic can also infect the urinary tract system, such as the pinworm infestation. And for the fungi, it will be the Candida albicans. And the next, viral. Viral is actually rare, but it also can infect the urinary tract, such as the cytomegalovirus, rubella virus, and also the adenovirus type 2. So next we move into the pathogenesis. Actually, I took this what we call this diagram because it will be easy to what we call to memorize. So the first one, which is the pathogen or bacteria, they colonize to the urethra, and when they colonize, it will be ascend to towards the bladder. When the pathogen colonize and it will ascend to the bladder, it will penetrate, and also the bacteria will replicate and also forming the biofilm. So bacteria ascend toward the urethra until they goes to the kidney. So when they goes to the kidney, it will be infect to the what we call renal parenchyma cell. When they infect to the renal parenchyma cell, it will cause the inflammatory condition. So this is condition we call the pyelonephritis. And also when it will go worse, it will be lead to the acute kidney injury. So next, this is the sign and symptom. Actually, I divide by two, which is for the infant and also the children. Actually, the sign and symptom for the UTI, it doesn't have what we call specific same symptom. Maybe we need to have the what we call combination of the clinical feature, because it may be some pediatric have a fever, but just fever, maybe only some other infection. But in this case, we need to know about some signs symptoms such as the fever, lethargic or porphyrin, and also the septicemia. And for the children, we can see maybe they have what we call abdominal pain or loin pain, and also for the flank pain. So you can see the children has also the what we call hematuria. So as I say, hematuria is the symptom for the what we call acute hemorrhagic cystitis. So we move to the next, which is the complication. So for the complication, the first is acute condition, which is the patient will have a dehydration because of the inflammation of the bladder. So when they have the inflammation of the bladder, it will be what we call increase the viscosity. Okay. Okay. So we proceed to the next, which is chronic the condition, which is for the hypertension. So it's really due to the renal parenchyma, what we call disease or hydronephrosis. And also, as I mentioned, at the end of the pathogenesis, it will lead to the acute kidney injury. So it will impair the renal function and stage the renal disease, and also it will lead to the renal abscess and also the scarring. So we're moving on to the next, which is the prevention of the UTI. For the prevention UTI, actually you need to the what we call take the high fluid intake, which is to produce the high input because you want to reduce the dehydration, and also you need to regular voiding because you will be release some symptoms such as just okay. Next we move to the ensure complete the bladder emptying, and also we need to prevent the constipation because it is the risk factor for the UTI, and also you need to have the patient pediatric need have a good perineal hygiene, and also need take the antibiotic prophylaxis, and also some books say lactobacillus acidophilus it will what we call it will protect it will against the UTI infection because it is a probiotic and it will dominate the urogenital flora of the healthy, and they suggested and they what we call they restore of the urogenital flora back, and also they dominate the uropathogen. So we move to the last one, which is the approaching to the UTI pediatric patient. So for the first, this is my example case scenario. Abdul have 2 months old infant. They stopped feeding, and also they had a high intermittent fever for 3 days. So he was referred to the hospital where he had an infection screening. So the next first, we must to take the what we call the most important. We must take the history taking. So history taking, what we call it is important to get a diagnosis. So as I mentioned, in UTI there is no specific sign and symptom, so we can we can more ask about sign and symptom to the patient, because it's actually in UTI we need to have a combination finding, because maybe some patient came to the clinic and have some symptom with fever and back pain, and also they have a suprapubic discomfort and also some associated symptom, and also the urinary tract infection. So the first one for the history presenting illness. So as I mentioned, we need to know whether have patient have a fever, flan or back pain, and also the abdominal suprapubic discomfort, and also some need. We need to include the risk factor also in the. We need to ask whether they have a risk factor of UTI. And for the next, past medical history. Actually, the vesicular reflux is the risk factor of the UTI. So we need to ask more than about the this history for the recurrent UTI and also chronic constipation and also circumcision. Sebab because when they do the circumcision in the village, maybe it not the proper hygiene. And the next for the drug history, actually we must to know about the what we call either they take the medication such as the nephrotoxic drug. Okay, so we move into the next history taking, which is we need to know the any urinary tract abnormality or alternative diagnosis. So development history we need to know also, and also for the nutrition history. So maybe some patient have any sufficient intake of the nutrients and they will be have a lost appetite, because the sign and symptom for the infant, they what we call poor feeding. So maybe lead to the lost appetite. So for the social history is also important, because for the sexual abuse and also the socio-economic, because maybe yes, they have they live in what we call urban, they live in the pendalaman or in the village. So we move to the physical examination. So in infant or younger children with pyelonephritis usually have no localizing finding, but they are febrile and also often irritable. So in this case, in general examination, so the first one, we look the patient, which is the conscious or the alertness of the patient. We need to see whether the irritability maybe, and also we need to see they have a pallor, jaundice, and also the lethargy, and also we need to see whether they have a sign of malnutrition. So for the vital sign, we need to know about the temperature first, because we need to know they have a fever for the infection, and also for the blood pressure, it will be lead to the hypertension, and also the respiratory rate, and also the anthropometric test is also important in the physical examination. It just not only for the UTI, maybe it all what we call all the cases, we need to have the anthropometric test. So for the specific physical examination. So in this case, the first one we do for the abdomen examination, we start with the inspection. We see whether it's any inspection scar or any tendon, what we call distended or tendon. So next we move to the palpation, which is we need to palpate the bladder and also the kidney, and also we need to palpate whether the abdomen is tenderness, or and also we need to palpate the scopubic. Maybe they have a tenderness, and also the back of costal vertebral angle. So as you can see, that is the as you can see, that's image. Okay. It actually show the how you palpate the costal vertebral angle. So in abdominal examination also, we need to know whether they have an enlargement of bladder or kidney. And also we need to have what we call external genitalia examination, because we need to know whether they have an anatomy abnormality, or maybe some have a sign of irritation, pinworm, and also vaginitis, trauma, and also sexual abuse. So as you can see, for the abdominal examination, all the children with pyelonephritis have tenderness on the fan and also the costal angle, where for the cystitis, it may have only the suprapubic tenderness. So you can chop the important. Okay, so the next, after we do the physical examination, we need to confirm the diagnosis. So we need to we need to do the next, which is the investigation. So actually investigation is divided by two, which is lab investigation and also the screening investigation. So for the lab investigation, so the common that we order is the food blood count, because in infection we need to know whether they has what we call clinical finding, such as leukocytosis, and also neutrophilia, and also increase the CRP and also the CSR. So for the blood culture is also important, because we need to know maybe for the for the bacteria, and also growth. Okay. And the next, we proceed to the serum procalcitonin, which is we can see the finding, which is the serum will be increased because of the pyelonephritis, and it will increase risk of the renal scarring. We can detect that. Okay, so we do some urinalysis. As you can see, we can see the pyruvia, and also we need to culture because we need to know about we need to detect the organism. Maybe it will be E. coli, maybe it will be Proteus. So we proceed to the investigation, which next investigation, which is the imaging screening. So the first one, we need to do the ultrasound scan. So it actually is recommended for in all children below 3 years and above 3 years old with a condition seriously ill with UTI and also the palpable abdominal mass. And for the ultrasound scan, we actually to know and we need to see the dilatation of upper tract, maybe renal size, and also the anomaly. So next, we can do the MCUG, which is mid-urethral cystourethrogram. So to detect the what we call VUR and also infravesical obstruction, and this is not recommended for the first UTI, but it may be considered when patient have infant with current UTI and also with infant with associated poor urinary system and also have a palpable abdominal mass. And the last one, we do the DMSA scan, because it is a radionuclide scan. It is the what we call the dimer
Dimercato,
ah dimercaptosuccinic acid. Okay, sorry. To assess the renal morphology, structure, and also the infection. So they use the technetium-99 radiation. Okay, so we proceed to the last one, which is the management. Actually, management is actually the aim is to reduce the infection and also to prevent the urosepsis, because for the management, for the prognosis of the UTI, it will lead to the urosepsis, VUR, and also pyelonephritis, and also recurrent UTI too. So the aim for the management also to prevent the complication and also the recurrence of infection. So for the outpatient, most children older than 2 months with UTI can be safely managed as outpatient, and we follow up. So we just only give some medication, such as for the upper urinary tract, we may give the trimethoprim and also cephalosporin. As you can see in this diagram, it shows the drugs that we give, such as the ceftriaxone, and also cefotaxime, and also the ampicillin, gentamicin. You can see, right? Okay. Next, when the when the patient is failure to respond for the outpatient therapy, we maybe we need to have admit, okay, so to the ward, which is we need to provide the appropriate IV antibiotic therapy. Maybe it will indicate for the children with a suspected UTI, depending on the severity of their symptom, maybe it will be chronic or not. So some very young infant, those presenting with a toxic appearance, and also the severe dehydration, vomiting, or intolerance to the oral medication should be considered for the hospitalization. So for the last one, for the prophylaxis management, it's actually aimed for the sterilizing the urine in order to prevent the renal damage of the renal scarring or some chronic condition to the renal. So prophylactic therapy should be considered in children with a history of recurrent UTI. Maybe they have some immunosuppression and also the partial urinary obstruction, and it will be continue until resolution of the underlying predisposition. So that the table that I give it is the example of the drug for the prophylaxis management. So you can see for the ampicillin, it will take 20 milligram per kilodose once daily. Okay. So I think that's all from me. Thank you. Any question? Sorry, my profile.
Your references must be adjusted, please.
Okay.
We need to assign someone to write for us how to write a reference.
Okay, sorry.
Okay. We must start now. We still have 1,000 a day. If we practice everything in the correct pathway, it will be, inshallah, a good advance in this time.
Okay.
not just the book you must write. You must know who will write for this for us, how to write. You will be the one.
Yes.
Okay, any questions for Fadil? So I would like to ask you, Fadil, now.
I don't know. Maybe that's not like.
In our more, which is most common, boys or girls for UTI?
Can you repeat the question?
The incidence of UTI, is it common in boys or girls?
Yeah, common. For me, it will female because the long of the ureter, and also because of the female, it's different between boy, because boy, the ureter of the length will be more longer, so they have some protection. But for the female, they have many what we call predisposed factor for the infection.
Okay, so it is, yeah, so it is very important just to know in the first month of life, it will be boys more than girls. Then after that, it is a girls. Okay, and it is a very important just for counseling the family. As I spoke before, we must have a good relation with the family. We must give them our knowledge, medicine without jargon. It's a simple lay language they can understand. Usually the problem is that many mothers are cleaning the stool before genitalia. So their hand will not so clean, so they can transmit the organism. Even if you are using like something, it is very important just to educate them. Clean from anterior, then you go to the posterior orifice. It is very important, okay? At the same time, if there is any infection, any constipation, because if anyone has repeated constipation and he is trying to sit on the toilet for a long time, waiting to void, he can get easily UTI. Okay, so there is some important point. The other point for neonate also, if the neonates got UTI, it is very important, okay, to rule out any anomalies as you speak, which is that VUR, vesico-ureteric reflux. Yes, very, very important, and we must know that the unit for UTI, they need IV, at least until the case is completely settled for about 7 days, and we need to continue maybe for another 3 or 7 days, oral. So it is very important, and you need to rule out vesico-ureteric reflux. That's why Fadil spoke about the MCUG and DIMSA. What is the benefit of DIMSA scan?
To see to assess the renal morphology.
What else?
Structure and also function of the renal.
You are very diplomatic. Remember, DIMSA has a letter S. DIMSA, so we are searching for fibrosis. The issue of repeated UTI, it will cause fibrosis of the kidney, yeah, and this fibrosis will decrease the kidney volume, and with time, the patient can go for chronic renal failure. That's why take care about infection in the small babies, okay, below 2 months or below 3 months, and more attention is given if it is accompanied by fever and other signs like vomiting and like that, because it denotes where is the infection now. If the patient has fever and rigor and it is in the upper, I mean it is pyelonephritis now. Because infection of the urine, I have two levels, lower or upper. If it is upper and go to the kidney itself, it is very dangerous. That's why the VOR are important, because it allows the urine not on one direction. It will allow the urine to come back to the kidney. And sometimes the urinary bladder contains some bacteria, okay? So bacteria will go up to the kidney. It will cause pyelonephritis, which is a very dangerous. Okay? And don't forget that infection of the urine need to be, analysis of the urine need to be done in most of the cases if you have severe infection or prolonged fever or like that. Okay. Good. I think today we are able to go through the many points about the urinary tract. For nephrology here in our pediatric protocol, we have, they have spoke about glomerulonephritis, nephrotic, acute kidney injury, okay, neurological bladder, antenatal hydronephrosis, and hypertension. So you need to read it, please, especially hypertension in children, okay, and acute kidney injury. All of you need to go through the nephrology part of our pediatric protocol. And I used it to tell you like that. The one who have protocol is the same like the one who has a father. He has reference for himself. It may be his father is not the best one in the world, but he is a very vital and very important to have protocol, to start by it, to know what is inside. And for any presentation, we are starting by this one, try to document it, okay? Don't forget to keep it with you, try to go through it, try to pick the general lines, the general indication, because really it is a very valuable book, okay? And I recommend everyone to have soft and hard copy with it, okay? The last point now, while we are speaking again about the kidney problem, we must know again that the kidney is a part of the abdomen. So while we are examining, I need to repeat with you because hoping I can see you soon, inshallah, in the words, okay? How to examine the abdomen. I think we got it in the lecture, but I just need to, as if you are practicing it now, okay? If I am going to examine the patient with gastrointestinal tract problem, I will do about 4 or 5 jobs first. I will introduce myself, good permission from the family, okay? I will hand rub or hand wash. I will positioning the patient. I will expose him. All these are vital. And don't forget to clean your hands because it is for the best interest of the child not to infect him. And I used to tell that. Remember that if you are doing wudu, you must wash your hand. This is ibadah also. To examine the patient and to prevent infection to him, you must wash your hand between patient before examining the patient, after touching even the situation of the patient, okay? Then you are going to make observation. Don't rush to go to the inside the abdomen of the patient. No, start by coming backward with one step and get a look for the patient. What about the patient? Maybe the patient has puff in his face. So now I will come to the first and the second presenter, which is either nephrotic or nephrotic. Okay, the patient doesn't have swelling but has growth is not normal. He is very small. He is like that. He may have fistula of dialysis. He may have. So I must put an impression. In pediatric, you must do that. If the patient looks normal or abnormal facial features, it may be baby with Down syndrome and have UTI. I mustn't forget it, okay? So number one, he looks normal or abnormal. Number two, what about his growth and development? He is delayed or normal? I will see this patient looks very thin, very short, very pale like that, okay? So I must comment for that and I will send, I would like to plot him in centile chart. The third one, I must be able to comment, is there any acute condition? Maybe the patient has convulsion, has respiratory distress, has in pain, okay, chemosis, bleeding, whatever. And I must comment about the patient. Is there any something special? It may be one patient has NIPS, one patient has connected to IV fluid, one patient has oxygen. I can see beside this patient like metered dose inhaler. I can see that this patient a sample of urine, which is color. I must be very observant. Okay, so number one, I introduced myself. Number two, I didn't hurry to go to the patient, even if I can do it from the bedside, just near the leg of the patient, and got a picture, and then I will start after that peripherally. I mean peripheral, I will start by give me 5 to see the hands. Is there any clubbing? Is there any cyanosis? Is there any signs of chronic liver disease, whatever, tremor, like that? And then I will check the pulse, and we must know how to check the pulse, and then ask for blood pressure and the respiratory rate, which is normal. After that, I will start from the head, and this is the eyes. It may be the patient has jaundice, has any problem, okay? And then for the mouth, and then for the jugular vein before coming to the abdomen. So if I ask you to examine abdomen or gastrointestinal tract, you must do all this. If you practice it every time, it will be very simple. It will take maybe a few seconds for you or 1 minute to finish that, okay? After that, for the abdomen, I must start again to observe. As we speak with your colleague for presentation, is there any distension? Is there any edema? Is there any scar? Sometimes you may miss any scar. Is very dangerous because it is not normal to have a scar. So if you find a scar, you must comment and you must measure it and tell me why this scar. It may be in the size of the appendix or inside of cholecystectomy, or it is for splenectomy, for exploration, for hernia, for renal biopsy, which will be on the back, a small scar. It may be another scar in the abdomen due to ventriculoperitoneal shunt. So you must be able to comment about the scar also. And then for palpation, take care. Don't hurry and start the palpation or getting any part of the baby without asking him he has pain or not. Does it suck it or not? Okay, so it is very important to ask, is it suck it? I'm going to palpate, is it okay? And start by superficial and then by deep palpation. And don't forget, we have 3 organs, not 2. We have 3 organs because most of you, he is presenting for me nephrotic syndrome and they forgot to examine the kidney. So you must start by examining the liver, where from the right iliac fossa and go up. And don't forget to do percussion and measure the liver span. And then from the right iliac fossa also will go in the direction of the spleen and palpate the spleen and also do percussion for the enlarged spleen for TROPS area and other. So it is very, very important. And then come for the kidney by palpement. If you are able to good palatable kidney, so it means it is enlarged one. If you do. So after that, even you didn't yet finish, you must do shifting dullness, transmitted thrill, okay? And after that, still we need to auscultate the abdomen, okay? About peristalsis, about any bruit, especially in the site of the kidney. And still you didn't finish. You must ask permission. I would like to look for the genitalia. It may be the child has edema, has hernia. Sometimes the child has abnormality in the genitalia or undistended testicles or whatever. So you must ask, remember that the genitalia is a part of the abdominal exam, but you must give the dignity of the patient. If you need, you must get permission and you close the curtain and all these issues. Okay, and even after finishing the abdomen, you must ask yourself, anything else I need to examine or not? I mean, if the patient has, like our case, has edema or ascites, so I need to check the lower limb. I need to auscultate the chest, like that, okay? If the patient has another problem, I must ask myself, what is the other? Is it clear? Hoping, inshallah, you will start again and again. I'm advising you, inshallah, Allah make your days are blessed and full of achievement, but you have about 1,000 and plus days. Every day you must build your ability. Every day you must treat in medicine. Yeah, you can finish this one if you wish. Instead of wasting your time, you can read. Any knowledge will come to you, will help you for some situation to diagnose patient, to come to the conclusion, to make differential diagnosis like that, okay? So it is very important, even if every one of you are able to do like a file from now, file for pediatric, I will put it, most of the cases I presented or I attend, I will collect all the seminar which we did for pediatric, I will try to do all that job. If you are doing like that, so we are building, because Allah give us unlimited memory, but we are using very little of it. But we need to build up the memory inside our mobile. But why 46? Make it 128, make it 1 tera even. No, don't forget that no limitation for you other than you. So then build up your WhatsApp and the other, and forget to build your future, because our really our job in medicine is not simple. It's amana and related to the future, either mortality or morbidity. I know many situations we are not the responsible one, but we can do a better job. We can help for everything. Okay, that's why reward from medicine from Allah can be very high, but also punishment can be very bad. Hoping, inshallah, to see you again, and hoping to meet together in the world to start to see some cases. We just have one patient, query infectious mononucleosis with suspected glomerulonephritis. I don't know it will be confirmed or not, but you must. Most streptococcal are the most common, but some viruses can do. But immunology can be the cause, like IgA, but it is secondary. And that's why, for my last words, remember that any disease, it is like a tree, it has a stem and has root and fruit. Again, any diagnosis has a stem, but it has root and fruit. This is a nephrotic syndrome. Okay? What is the root? Is it primary or secondary? It may be secondary to SLE, it may be secondary to infections, hepatitis, secondary to malignancy, secondary, as your colleague spoke about. And at the same time, it is nephrotic syndrome by this criteria, 1, 2, 3, 4. And then I will ask myself, is it complicated or not? This is a bad fruit, like shajarat al-zaqum. So I have root and the fruit, which is give you the bitter. This is a case of primary or secondary nephrotic syndrome under control, and there is Cushing syndrome features. So now I am doing the best job. Okay. So remember that. Try to put it and try to consider any complication, especially if there is any organ failure. I mean, if the heart, I'm examining the heart. What is the sign of heart failure? I must know. I'm examining the respiratory. What is the sign of respiratory? Is there severe respiratory distress and cyanosis, and I must add blood gas. Okay, this is the same. The kidney, what is the sign of kidney failure? What about the heart, the brain? Even there is no brain failure, but there is encephalitis and there is unconsciousness and disturbed sensorium like that. So even you must ask yourself, is this organ are doing optimum or not? Okay. See you again. Do you need to ask any points?
Doctor, I just want to know my marks.
Oh, okay. You forgot to write a good.
Difference.
I need you to make a good presentation, because not a good to put a lot of picture and like that. It is advisable if it is related, because now most of the world are going to consider more professional in presentation, just a simple one, white and black, and try to put a picture which is needed. Good to do some simple decoration or like that, but not a lot of pictures. Okay. Yeah. What did you suspect?
No.
No, not so low. It is 7 for you.
Okay, thank you.
You need to write this point which I asked it to correct, and all your colleague, and you need to write for them how to write a reference. Okay, inshallah, and you can even update me for that. And all of you keep free. I am responsible for you, but by remote. If any one of you has anything I can need, okay. But my top advice is your clinical sense. Practice more and more as you can, inshallah. Okay, even you can open and see video for a patient of, like, most common cases, thalassemia, patient with G6PD, patient with nephrotic. You can open and you will find in the video, just see the patient as if mock one until inshallah you come and saw it on live. Assalamu alaikum wa rahmatullah.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Alaikum.